Hello, everyone. We're so happy you could join us for our blood pressure webinar today. My name is Lily Mazminian, and I am a project coordinator at Health Insight Nevada, and I'll be your host. Let's go over some quick housekeeping items. In this Zoom webinar platform, attendees are placed on mute and don't have the ability to share their camera. If you have any questions during the presentation, please either type them into chat, and that'll be at the bottom of your screen. Any kind of questions you have, and our subject matter experts will answer. Or you may type your questions in the Q&A box, also located at the bottom of your screen. And we'll gather them for our speaker and for her to answer at the end of her presentation. But before we begin the webinar, let's have a little background about Health Insight. So who is Health Insight? As many of you know, Health Insight is a quality and innovation network, quality improvement organization serving Nevada, New Mexico, Utah, and Oregon. The QIO program is grounded in contemporary improvement science and focuses on helping providers and teams across every element of the healthcare spectrum deliver the right care at the right time, every time. The program has evolved over the last several years to become a keystone for ensuring people with Medicare get the care they deserve, which ultimately improves care for everyone. I'm delighted to work with many dedicated and great people at Health Insight, one of them being Vicki Kohler, our presenter for today. Vicki, can you introduce yourself for our audience?
Hi, thank you for having me today. I'm Vicki Kohler. I came from the clinical industry with background in working in clinics and developing medical assistant training programs. I've worked at a couple of our local community colleges as a medical assistant instructor and also the department chair of those community colleges for the allied health programs, overseeing HIT, medical assistant, and several other programs. And then I became more involved in the public sector, working as a heart and stroke prevention coordinator for the state of Nevada Public Health Division. And now I'm here at Health Insight as a project manager. So today I will be talking to you guys about working on taking blood pressures properly and working to understand why we need to ensure we're taking blood pressures properly. The objectives for today are understanding the new algorithms for blood pressures and their stages, obtaining blood pressures properly for placement on patients, and working with patients to ensure they are prepared for their blood pressure, how external factors can affect blood pressure, and last, the effects of high blood pressure on patients. So, jumping right in, this is the new blood pressure algorithm that has come out recently from the American Heart Association, and what you can see is that they have changed some of the levels. The biggest one being that we used to talk about 130 to 139 systolic being pre-hypertensive, and now it's actually considered hypertension stage 1, and the 80 to 89 range diastolic is now considered high blood pressure instead of pre-hypertensive. So you can see that we've moved from those, and also that the hypertensive crisis stages have been altered slightly as well. That I think a lot of us haven't really caught great information about this, and there hasn't been a lot of promotion in the clinical industry necessarily to talk about this, and we need to spread that word to make sure that we're working with our patients properly. So let's talk about obtaining these blood pressures and getting the best quality blood pressure we can for our patients. One of the facts, and I can certainly send this over if you guys would like additional information, is we know that patients monitoring their blood pressure at home to avoid things like white coat syndrome and stress, things of that nature, is the best indicator of acute events. But we get our patients in the clinics or in the facilities where we're working. So things we can do to prep our patients, and we can talk to our patients about receiving or having them do to get the maximum benefit. First, make sure that we talk to our patients about not participating in physical activity at least 30 minutes prior to their appointment. They should avoid using or consuming alcohol and caffeine products 30 minutes before the appointment time and the vital is obtaining. We want them to obviously not use tobacco products, but if they are using tobacco products, we want them to abstain for that for 30 minutes prior to coming into the practice or coming in and taking their pressures. and we want them to relax while we're taking their blood pressures. Some other things that we should consider is that we want them to use the restroom at least 15 minutes prior to us obtaining pressures for accuracy, to eliminate and reduce as much stress as possible. And I think we do a great job of talking to patients about eliminating and reducing stress for a multitude of reasons, but it does actually affect their blood pressure. We don't want them wearing tight-fitting clothing the day of the appointment, and it's really important for them to get good night's rest. So that takes us to the next piece. We've talked about how patients can help us measure their blood pressure accurately. Now let's talk about, as clinicians, how we can measure that blood pressure accurately. So the first part is place that patient in a comfortable position with their back and feet supported. We want those feet flat on the floor or on a stool or the trays or whatever it needs to be if they're sitting up. And we want to make sure that their back is supported. Verify that they don't have their legs crossed and that they've rested for 3 to 5 minutes before we actually attain that pressure and haven't done any physical exertion like walking, things of that nature. And you can see here on the screen, I don't think we do a lot of speaking about how does that affect the patient's blood pressure. So just not having their back and feet supported can change the pressure and increase it by 5 to 15 milligrams of mercury per incident. Not having their legs crossed. If they do have them crossed, we're looking at possible 5 to 8 milligrams of pressure inaccurate. And then last but not least, if we don't give them that relaxation time, we can alter their pressure by 10 to 20 millimeters. So the next thing we don't do very well is making sure we're using the appropriate cuff size for our patient. So on the screen, you can see some examples of some blood pressure cuffs. There's a range on these blood pressure cuffs on the internal side of the blood pressure cuff, and there's a white line on the edge of the blood pressure cuff. When you place the cuff around your patient's arm, where we should typically be taking them, the white line on the end of the cuff should fall within the range marked on the inside of the cuff. If it doesn't fall within that range, the cuff can be too small or too big. In this slide, we talk about if the cuff is too small, it can inaccurately raise the pressure 10 to 40 millimeters of mercury. But if the cuff is too big, it can give us an inaccurately low reading also. So it's important that you're engaging the right size cuff for our patients. There is 5 sizes. So a lot of times we're going to use, for adult patients, the adult or the child or the adult large. Some other things we need to make sure we're doing when we're measuring vitals on a patient, including blood pressure, is that we want to make sure we've exposed that patient's bare arm, again, because going over clothes can mitigate that pressure and make it inaccurate by 10 to 40 millimeters of mercury. We want our patients not to speak while we're obtaining their pressure because that can give us an increase inaccurately of 10 to 15. And we should make every attempt to take the patient's pressure on their left arm with the arm supported at the level of the heart. So not just that they're holding their arm up for you, but that they're using that left arm on the bare skin and that the arm is supported at heart level. So I think this is something a lot of us don't do the best with, but this is very important. The reasons we wouldn't want to use the left arm for this patient obtaining a pressure is that they have an IV or a dialysis shunt or some kind of port there, if they've had a mastectomy, if they have some kind of lymphedema issue. Those are reasons to attempt on the other arm if necessary, but we really should, and also a mastectomy. But the real thing we want to do is mitigating any of these circumstances. We want to take that pressure on the left arm to get the most accurate pressure. So some additional factors that we should talk about that affect the blood pressure. If the patient has that full bladder, we're going to see an increase. So this is a great reason why we would want to do this and make sure we get them to use the restroom. If they have a full bladder, we're going to see an increase in their blood pressure. If they're in pain, we're going to see an increase. There's not a lot we can do about fixing that pain situation other than possibly giving them, trying to make them more comfortable in the chair or things of that nature. But we do want to talk about that, the pain and how we can possibly mitigate that prior to obtaining that pressure. If they're showing signs of labored breathing, we're going to want to take that extra time to get them I know previously in these slides we were saying give them 3 to 5 minutes to relax and get situated and not be exerted. But should we still see that they're exerted or they have labored breathing, we need to give them that extra time, because if we're obtaining those pressures when they're exerted and have labored breathing, we're going to see an inaccurate increase. If their arm is tense because we're not supporting it and we're having them hold it up, or if we've made them somehow, as clinicians working with them, made them uncomfortable, we want to give them that time to relax or something of that nature, so we don't increase that pressure unnecessarily up to 15 points. And last but not least, there's not a lot we can do about white coat syndrome, but if the patient is feeling anxious, we know we don't have a lot of time, but we can still work with them and talk to them about not being so anxious, or make them feel more comfortable, or listen to what their needs are or concerns are if they're coming in to see us. A lot of times they have a list of to-dos or questions or concerns. If we need to mitigate those in the beginning for some that we can to get that pressure down, it's really not best practice or effective for us to measure their pressure when we know they're anxious and we haven't mitigated it, because we don't want to see that 30-point higher blood pressure. It's not going to be effective, and it's not going to be good for the patient care plan. So let's talk about the basics, how blood pressure affects the body. So I think a lot of times, especially with this group, we talk about, and know, when we talk about high blood pressure, we're talking about issues with possible heart attack or heart failure or effects on the heart. We talk about how it can possibly increase risks of stroke or cause strokes in some occasions. But some other things that we don't talk often enough about is high blood pressure can also affect a person's vision. In some cases, it can increase or cause blindness. It obviously can cause atherosclerosis because of blood vessel damage, but not only is the blood vessel damage increasing the blood pressure, high blood pressure compounded with atherosclerosis further damages those vessels. And last but not least, obviously, when we don't think about it, don't talk about it often enough, but high blood pressure overexerts the kidneys and can begin to cause kidney failure. So then the next thing we can talk about with our patients is, should we recognize high blood pressure? What kind of things can we do to give them opportunities to lower their blood pressure, besides talking about the hereditary risk factors, or previously we mentioned that anxious patient, things they can do to help with their anxiety or how they can help reduce their stress, things that we can do to improve their blood pressure and help that they can actively participate. In the current industry, as we all know, we're being prompted to talk more about self-maintenance and self-monitoring. So these are great activities that the patients can partake in to engage and work on lowering their blood pressures themselves. The first one being leading an active lifestyle. We know that if they exercise 60 minutes a day, either all at once or in 20-minute increments 3 times a day, it's beneficial to their health. Even if we have those patients that push back because they've had a sedentary lifestyle, or they have an obesity issue or pain or difficulty walking from strokes, or the heart disease situation they currently have where they don't have a lot of strength and they get exasperated easy or exerted easy, we can even start talking to them about smaller increments. But let's start talking to them about getting up and moving. I've suggested to a patient once, like, maybe just make it a goal for a couple of weeks to just walk to your mailbox and back. Like, start small and work big. But it's better than saying, go exercise for 60 minutes a day and putting that thought process in their head that we need to exercise for 1 hour every day, and how do we work that in? Another way a patient can mitigate is eating less salt, limiting and reducing sodium intake. So the average American is consuming 3,400 milligrams of sodium primarily through salt a day. The USDA recommendation is only for it to be 2,300 milligrams per day. And they even break it out further that if it's an African American descendant or somebody who's 51 years or older, that they should also reduce it based on chronic conditions to less than 1,500 milligrams per day. I think it's also very important if we're engaging patients in this conversation that we're not just speaking to reducing sodium, because a lot of times they do hear about that as like reducing table salt intake, so they'll do other options. We also need to consider talking to them about paying attention to the labels of the food they're eating. Is there a lot of sodium as a preservative in their pre-packaged meals or canned goods? And what other kind of salt substitutes they could possibly use to help mitigate some of this process. The next thing that would be great to talk to our patients about is watching their alcohol consumption. So obviously we don't want them doing illicit drugs, and we have that conversation, but alcohol goes along with this. Not that they go hand in hand, but a lot of times in clinics we feel like they do, or in healthcare settings. So the USDA recommends 1 drink per day for women and 2 drinks per day for men. So a lot of times we don't think about it, but it's a risk factor for raising their blood pressure, for their body trying to work to remove some of the overconsumptions that patients partake in. So this is a great way, offering them interventions or support programs, something they need if you recognize they have a problem. But just talking to them about reducing their alcohol consumption can go a long way, especially when there's great materials about if you drink wine, it reduces your blood pressure, increases your health, things like that. We don't want to make sure that our patients aren't getting the wrong messages. And another one is lead a heart-healthy lifestyle. So when we talk about leading a heart-healthy lifestyle with our patients, furthermore, we can talk about drinking plenty of water. So we need to talk to them and engage them about drinking that 48 to 64 ounces a day and 6 to 8 glasses a day, or maybe better times a day that they could stop and remind themselves to take a drink of water. I have worked with a patient once who set calendar times on their iPhone that's reminded them to drink water. So she would literally stop in the middle of meetings and drink her water, but it was great. She started getting water intake, and she was only previously drinking about 1 glass a day. So it was huge for us, and it did directly affect her blood pressure. We also need to talk about eating healthy to those patients. We need to talk about the food plate now, not the food pyramid. If you're paying attention to USDA recommendations, talking about the food plate, making healthier choices, opportunities for cooking with different materials. I feel bad for patients when they watch these cooking shows and they're like, always add the salt and add the pepper and you'll get there and it'll be great. And then the patients come back to us and they say, well, everything says add salt. What other opportunities can we offer them, or what recipes can we offer them that are more healthy lifestyle? If they're working on a budget, what opportunities do we have to offer them resources in our community to get healthy foods instead of prepackaged cheaper foods? And then avoid the tobacco products. We really need patients just to stop using tobacco products. It's a long running disparity, and we've been trying. I know most states have some kind of tobacco quit line that offers intervention and tobacco cessation programs and support groups, but we really need to talk to these patients about this. This is beyond just clicking in our EMRs, that we've had conversations about quitting tobacco, because that doesn't necessarily become the most effective opportunity. So we really need to talk to our patients about avoiding those tobacco products, giving them positive solutions. And in some cases, like with the quit lines, we can give the patient the information, but they may never engage. So what we can do is actually contact the quit lines and have them reach out to our patients. A lot of states offer that opportunity through their quit lines, that you can contact the quit line and the quit line will reach out to the patients instead of waiting for that connection from the patient to the quit line. So the last thing that I always like to mention when I'm talking about some of this information is that there's also self-monitoring blood pressure programs happening in the state with the communications with AHA programs. So American Heart Association has worked to give patients blood pressure, or not even patients, patrons blood pressure cuffs through their local barber shop to measure their blood pressures daily or once a week at the same time to report back to their clinics. But there's a lot of great self-monitoring blood pressure programs that are happening throughout the communities in the nation. And one that I was involved with previously, the feedback from the patients and getting the patients in line and getting them under controlled blood pressure instead of out of control was actually a pretty quick turnaround, utilizing a self-monitoring blood pressure program and getting those patients taking their blood pressures every day and really being proactive in their health and their blood pressures. So I ran through these a little quicker than we expected, but does anybody have any questions?
So we'll open it up right now for anyone that has any questions. If you'd like to ask Vicki any questions, please let us know in chat, and I will open up your ability to ask Vicki a question, or you can type it in the actual chat room itself. But Vicki, we kind of have a question for you until we hear from our audience. So what can our callers do when they go back to their office or talk to their staff about how to take blood pressure? What kind of info should they take back with them about training or strategies that are the most important?
Sure, I think that's a great question. Some things we can do is take back to our clinics or organizations we're working with is to make sure that everybody's educated on the new blood pressure algorithm and the adjustments to those ranges. So we're more apt and in tune to look at those patients as we're taking those vitals and reporting back if we see a change that might be going into the higher level. As I mentioned at the beginning, with the algorithm, that 130 to 139 used to be considered pre-hypertensive, where now it's the first stage of hypertension. So those really have made an impact on what we see, because as we get into the older patients with chronic diseases and comorbidities, including obesity or tobacco use or alcohol consumption, things of that nature, poor sleep, high stress levels, we're going to see a lot of those patients now fall as hypertensive instead of pre-hypertensive. So that changes that conversation. So I think one of the first things would be to take back that algorithm and educate patients on, clinicians on it. The second thing would to be really stressing the way to obtain vitals, especially blood pressure, correctly, to make sure you've got that patient with their feet supported, their back supported if they're in a chair, that you're using that left arm exposed to the bare skin and supported, that you're making sure that they're not talking, that they're not exerted and giving them that time, or maybe having that conversation with them as you're getting ready to take vitals to help relieve some of their stress about the questions they may have, so that they feel more relaxed and comfortable as you move into it. But we really need to get into some of that working to make sure we're taking that blood pressure appropriately, not taking it on the right arm, or having the patient in a funky position, or their feet dangling a foot off the floor because of where they meet the table, or something of that nature. We really need to start supporting that for these patients.
Thank you, Vicki. And what do you suggest, and how often you suggest they should be training on blood pressure within their offices? What do you think would be a good time frame for them to be training, and how often?
That is a great question. I think it's important because a lot of times we assume as somebody's coming in with some training that they're following these issues these guidelines. And a lot of times some of these people that have been trained in the settings they were trained in didn't even necessarily get this information. So I think it's important when you hire a new clinician into the clinics or facilities that you give them an initial training on expectations. This is what we would like you to do when you're attaining vitals, to reset that expectation, and maybe you're going to help them understand things they may have forgotten or wasn't explained clearly to them. And then, I recommend that you have some sort of retraining every year, which I know a lot of people scoff at, and a lot of clinicians are like, oh, I already know this, why are we doing this again? But in my previous training realm, it was surprising to me how many people as clinicians have gotten so busy and so worried about the other bullets they've got to complete every day. You're asking the newest tobacco questions for the surveys, or doing behavioral health screenings, things like that they kind of start sidestepping and cutting corners. So just having that yearly quick presentation in services with staff, or having them join a webinar or a memo reminding them of the key bullet points, is always good, just to make sure and reiterate that this is our standard and we want to maintain it. The other thing that can be done about it is just in clinician areas, workstations, things like that, maybe hang up posters that talk about the key things like keeping their feet flat and their backs supported, or using the left bare arm supported, making sure they're not talking or using tobacco products immediately before. Giving some of those key tips and tricks and bullets in their workstations to remind them is also very helpful to them, because it's not stuff we think about every day when we're getting busy and worried.
Great tips, Vicki. Thank you so much. And you spoke about some pushback they can get from staff, as in we know this already. Are there any other barriers that you've seen when talking to staff about blood pressure measurement training that you can give them tips on to go back to talk to their staff after the webinar?
You know, some barriers I've seen in the past is where you have patients that complain that taking their blood pressure hurts their arms, so they're very resistant to it. And one of the ways we can mitigate that is when we're obtaining a pressure to make sure we not inflate the cuff over 160 millimeters of mercury. That way we're not overly squeezing their arm, making sure that you get that right cuff size, because if we're using too small of a cuff on somebody, even around once you get up to 100 or 120 on the sphygmometer, it still starts to squeeze their arm and make them uncomfortable. That's usually a good clue in that maybe your cuff sizing isn't the best. And then a lot of times it's the patients want to talk. They just think that they can keep talking to you and engaging you. So when I work to train clinicians, when we come to taking vitals, there's usually several pieces we're obtaining, right? So we're working on their blood pressure, their pulse, their respirations, their pulse ox, their temperature possibly. Maybe we're doing a quick screening. Maybe we're doing a foot exam for diabetes or things like that. When you're doing this stuff, to build in that time frame to give them 3 to 5 minutes to relax and de-stress and not be exerted, things like that, put those other things first. So maybe take the pulse ox or the temperature, or do your foot exam, or do one of your other behavioral health screenings or whatever you may be doing first, and then move down through that process and save the blood pressure for last. So the patient has gotten their comments or questions or concerns out of the way, so they're more apt to be quiet, so you can take their pressure. And not that we want to tell them to be quiet, but maybe they'll not be talking as much, so we can really get that accurate pressure without them exerted, without them talking, and really prep them without them knowing or working to get them where we need them.
Great. We have a question for you from our participants. It comes from Eldon, and he asks, how accurate are the blood pressure monitors that can be bought at Walmart?
That is a great question. Thank you, Eldon. So one of the things about any automated blood pressure cuff system is that it requires maintenance and calibration. So there's a few components that go into the accuracy of those blood pressures. The biggest one being that maintenance and calibration. If you aren't maintaining a calibration schedule per the package insert in manufacturer recommended instructions, then you can't validate and guarantee that that blood pressure is accurate. The second thing is specifically following those directions from the manufacturer. So if the manufacturer's recommendation is talking about taking it on the lower arm over the wrist with the patient's hand elevated or arm elevated, you really do need to follow those guidelines to get the most accuracy out of that monitoring system. So that's a barrier. And then last but not least, anytime you're using those automated systems, you are working with a system that's more computerized. If your patient moves, it's going to inaccurately measure that as as part of the blood pressure pulsation of those corticoff sounds, which in the pulsation. So that can really present a problem. I've seen cases where the automated systems are drastically inaccurate, and that comes from not doing that calibration or making sure the patient's maintaining and holding still or following the manufacturer's instructions. What we've worked on in the industries that I've worked on, whether it be training programs or in clinics, was talking to the patients, talking to the clinicians about measuring that first blood pressure manually and then using an automated system if there's another need to obtain a pressure to make sure that they do coincide with each other and correlate, or making sure that they are getting that calibration done and documented in a timely manner to make sure that we're maintaining that equipment. So the other thing also is, if you take a patient's blood pressure, and this could be through any system, if you take a patient's blood pressure and it's high, and it isn't something that's been noted before, or that's not known this patient has hypertension and this is their normal range, and that we're working to mitigate it, wait 5 to 10 minutes and take that blood pressure again. Give them further time to relax and get over being concerned about getting that pressure taken or other questions, and then maintain it and take it again. In clinics, we often recommend that you take the blood pressure with the patient vitals. If it's high, after they've talked to the provider and sat for several minutes, before they leave, take that pressure again and see if it's come down. Obviously, we want to document the lower pressure that's more accurate, probably for what the patient's needs are. Does anybody else have any additional questions?
So this is Lily again. So I guess our next question would actually be for our audience, and don't feel shy, please at least chat in. So in order for us as a team to help support you, let us know what your role is. What resources do you need? Do you need some training materials, staff training materials you can use for in-services, anything? We're here to support you. Let us know. We need to know what you need in order for us to be able to give you that support. So we'll give you a minute to chime in. And thank you so much, Vicki. This was really, really helpful, and I'm sure our audience really appreciates you being here with us and answering our questions. And we'll just give it a moment before we end our meeting. Oh, I see a question here, Vicki. Let me see. Okay, so we do need training materials from Joy. Okay, Joy, just chime into the chat, and if you can give us further info about what type of training material, or I can place my email address in the chat. You guys can always get in touch with me, and we can send that over to you at the end of the webinar. Seeing no other questions, we'll end our webinar. Thank you, everybody, for joining us today. We really appreciate you being here with us, and have a wonderful rest of the day and the week. Thank you. Bye.